Good morning. I'm Dr. Vikram. Moderator for today's topic is Dr. Sudhindra Rao. JAPI Journal, August 2020 edition. The topic to study the role of absolute lymphocyte count and RDW in COVID-19 patients and their association with appearance of symptoms and severity. Authors Deepthi Sharma, Ashish Dayama, Banerjee, Sudhir Bandari, Aishwarya Chatterjee, and Debapriya Chatterjee. Introduction to this topic, we start from what is COVID. COVID is WHO declared coronavirus disease 2019 COVID-19. It's a public health emergency of international concern. Etiology for this outbreak is a novel beta coronavirus named severe acute respiratory syndrome coronavirus SARS-CoV-2. Pathogenesis is not yet fully understood, but it causes extensive lung damage and it does appear to be associated with high initial viral load, neutrophil infiltration in the lungs concomitant with explosive elevated levels of serum pro-inflammatory cytokines and chemokines with a rapid and precipitous decrease of peripheral T lymphocytes. So therefore, clinical deterioration and tissue damage during SARS-CoV-2 infection may result in direct virus-induced cytopathic effects on maladjusted immune response. So one of the features of SARS-CoV-2 is global reduction in peripheral T lymphocyte and impaired immune response during acute infection. Circulating biomarkers represent this immune status. Present study was designed to analyze the occurrence of abnormalities in complete blood count, especially the absolute lymphocyte count and RDW in patients with COVID-19, and to establish an association with appearance of symptoms and severity of disease. This is the table which shows lymphopenia featured predominantly in symptomatic COVID-19 group with a median nadir of ALC of zero point 0.7 compared to 2 in asymptomatic group. So there is neutrophilia was present in both the groups with a median nadir of ANC of 7 in symptomatic patients and median nadir of 3.8 in asymptomatic patients. Usually the normal range of ALC is 1000 to 4000 and ANC is 1500 to 8000. The next is another figure which shows median lymphocyte count of 0.7 in mortality COVID-19 patients when compared to median lymphocyte COVID-19, which is 1.7 in normal asymptomatic patients. Neutrophilia was seen in both groups in patients. Median ANC in mortality patients was 7.2 and recovered patients was 4.2. Research objective is to study the role of absolute lymphocyte counts and RDW in COVID-19 patients and their association with appearance of symptoms and severity. Design is a retrospective observational study. Study period was April 1st to April 30, 2020. Methodologies, epidemiological, clinical, and radiological laboratory data were obtained, and COVID-19 positive cases were diagnosed in basis of interim guidelines of WHO. Categorized asymptomatic patients population satisfied following condition: epidemiological history, absence of fever or other respiratory symptoms, absence of typical radiological abnormality, positive RT-PCR for SARS-CoV-2 RNA. Symptomatic patients satisfied at least one of the following conditions, namely fever or any respiratory complaint, respiratory rate greater than 30, oxygen saturation at resting state less than 93%, or PaO2 by FiO2 less than 300, and also RT-PCR positive. Only laboratory confirmed cases based on diagnostic criteria recommended by National Institute of Virology in Pune were taken for analysis. Laboratory assessment consisted of complete blood count, blood chemical analysis, coagulation testing, renal and liver function. Statistical analysis was expressed on appropriate means and interquartile ranges. Categorically variables were summarized as counts and percentages in each category. Fisher's exact tests were used for categorical variables. P less than 0.05 was recognized as statistically significant. All these statistical calculations were performed using SPSS 17 software. Result comparison was done between 35 asymptomatic and symptomatic patients. All patients were Indian ethnicity in history of contact with COVID-19 positive cases. Notably, symptomatic patients were older than asymptomatic patients with a mean age of greater than 60 and asymptomatic patients at the age of 30, P 0.01. No significant difference could be appreciated between two groups in terms of gender of males 74% and 60% respectively in symptomatic and asymptomatic patients. On admission, leukopenia was observed in 3 patients, 8.5% belonging to symptomatic patient population, P less than 0.001. Lymphopenia was observed in 80% of symptomatic patients when compared to 11.5% asymptomatic patients, a difference of statistically significant p-value of less than 0.001. Laboratory reference value of leukocyte was 4,000 to 10,000 and lymphocyte was 1,000 to 4,000. Lymphopenia was observed in 28 patients with 21, that is 80%, and with 60% having moderate lymphopenia, absolute lymphocyte count of 0.5 to 1 and 7, with severe lymphopenia people having around 11.3 of asymptomatic had an absolute lymphocyte count of normal range. Lymphopenia featured prominently in symptomatic COVID-19 patients, population with a median nadir of 0.7 as I had told you, compared to a group value of 2. Serial profiling of such patients was done uh, and characterized based on host immune categorically identified and segregated. Patients who could eventually progress to symptomatic also was taken care, and they required intensive care. An ALC value approaching scale of severe lymphopenia 0.6 could possibly be considered as one of the indicators for early and timely admission supportive care in ICU. On comparing symptomatic and asymptomatic patients, 35 each, making use of Fisher exact test, was observed that admission of ALC stood out as a discriminating independent laboratory index that could substantiate appearance of impending symptoms with a p-value of less than 0.001. Neutrophilia was observed in all COVID-19 patients, inclusive of symptomatic or asymptomatic patients. Neutrophilia featured prominently in symptomatic COVID-19 group with a median nadir of 7 compared to 3.8 in asymptomatic patients, which is statistically significant. Laboratory reference value of neutrophil count was 1,500 to 8,000. Absolute monocyte count was comparable between two groups, and most patients in asymptomatic group had a normal platelet, leaving aside 2 patients who had thrombocytopenia. Thrombocytopenia was observed in 14 patients in symptomatic group. However, this finding is statistically insignificant in comparison to 2 groups. Red cell distribution width was slightly raised in 2 groups with a median RDW of 15.4% and 15.2% in symptomatic patients and asymptomatic patients respectively. This finding was not statistically significant on comparing sample population, though RDW values raised in COVID-19 patients as compared to normal. Comparison was done among patients who recovered and succumbed to COVID-19, and it was observed median age of patients who died was 60 years and that of who recovered was 42 years. Difference in median age was disease progression was statistically significant, p less than 0.01, an observation that possibly links to increased chance of mortality in patients with increased age. Decreased ALC of median value of 0.7 was persistently present in all patients who died of COVID-19 as compared to ALC of median value of 1.7 in positive patients who recovered, and this significant ALC value was statistically significant, p less than 0.00. Lymphopenia was seen in 18 patients, that is 82%, who died of COVID-19, and moderate lymphopenia present in 13, that is 59%, and severe lymphopenia in 5, that is 22.7% of patients. Neutrophilia was seen in both groups, median ANC of 7.2 and 4.2 respectively, in mortality and recovered group. This shows median lymphocyte counts in recovered and symptomatic and asymptomatic group, wherein the median leukocyte count is high in symptomatic patients, while median lymphocyte count is low in symptomatic patients, and median neutrophil count is significantly higher in symptomatic patients. Same thing, it's represented. Comparing death and recovered patients, median lymphocyte count and median neutrophil count was higher, while median lymphocyte count was lower in dead and dying patients. Discussion: since December 2019, COVID-19 was reported in Wuhan, has rapidly spread throughout the world. So it is similar to MERS-CoV and SARS-CoV. SARS-CoV-2 is also a member of beta coronavirus with human-to-human transmission, incubation period of 3 days, and low fatality rate. Coronavirus spread among humans, leading to spectrum of respiratory ranging from flu-like symptoms to ARDS. Infection by these viruses can cause sustained overdrive response of cytokines and chemokines, known as the cytokine storm, resulting in high incidence of immune disorders and mortality. So, the median age of patients in symptomatic group was higher than that of asymptomatic group. In present study, lymphopenia, a decrease in ALC was observed in 80% of symptomatic patients. Lymphopenia was reported in various types of viral disease such as SARS, MERS, and RSV. The existence of hypercytokemia in COVID-19 patients with lymphopenia could indicate a poor control of pathogen, as evident in critically patients with SARS, which was seen in 2013. These features of lymphopenia and hypercytokemia have been observed in associated with incidental increased severity, mortality, and dysregulated immunological response. Lymphocytes and their subsets play an important role in maintaining of immune system. As the immune diseases and other infectious virus can lead to dysregulation along levels and strata of lymphocyte subset. Adaptive immune responses develop precise and powerful immunity against viruses. Adaptive immune response to viral infection is exerted through the effective function of cytokine T lymphocyte response, which specifically recognizes kill virus in infected cells and release inhibitory antiviral soluble factor. Thus, a sharp increase in CTL count is expected in patients with SARS-CoV-2 infection. However, unlike the conventional immune response against viruses, SARS-CoV-2 is accompanied by T cell lymphopenia with a rapid decrease in both CD4 and CD8 T cell subsets. Another report indicated that reduction of number of CD4 to CD8 counts T cells in peripheral blood of SARS-CoV-2 infected patients similar to patients with SARS-CoV and was associated with concomitant hyperactivated T cells shown by high proportions of CD4 restricted HLA-DR3 and CD38 in double positive patients. Possible explanation for lymphopenia in COVID-19 needed further investigation. Potential underlying mechanism could possibly include virus may directly infect lymphocytes, resulting in lymphocyte death as lymphocytes express coronavirus receptor ACE2 and may be a direct potential target for virus. Infiltration of T cells and subsequent trapping of lower respiratory tract as well as immune cell death. Viruses may directly destroy lymphatic organs. Acute lymphocytic decline may be related to lymphocytic dysfunction, and direct damage to novel coronavirus to organs such as thymus and spleen cannot be ruled out. This hypothesis needs to be confirmed by pathological dissection in future. Inflammatory cytokines such as TNF-alpha, IL-6 are continued to be disordered and perhaps leading to lymphocyte apoptosis. Inhibition of lymphocytes by molecules produced by metabolic disorders such as lactic acidosis. Severe type of COVID-19 patients have elevated blood lactic acids, which might suppress the proliferation of lymphocytes. Viral infections would inevitably lead to activation of hypothalamic pituitary adrenal axis under stress, resulting in upregulation of endogenous corticosteroids, which may be involved in immunopathogenic mechanism of lymphopenia in COVID-19. No significant difference has been appreciated in symptomatic and asymptomatic patients. It is reported that RDW could act as an important independent prognostic factor for severity in COVID-19. Increased RDW in COVID-19 may be actually due to turnover of erythrocytes, which is increased, low inflammatory states resulting in insufficient erythropoiesis with structural and functional alteration of RBCs, such as decreased deformability leading to more rapid clearing of RBCs. Plasma cytokines such as interleukin-1 and tumor necrosis factor alpha, TNF-alpha attenuate the renal erythropoietin EPO production, blunt the erythroid progenitor response to EPO. RBCs are dynamic reservoirs of cytokines. Decreased deformability of RBC in severe illness leads to RBC lysis, release of inflammatory cytokines into circulation. This positive feedback could greatly promote the apparently shortened RBC survival and ultimately more morphological variations in cell. Conclusion: lymphopenia is an effective and reliable indicator of onset of symptoms and severity of disease in COVID-19 patients. Lymphocyte count can easily be obtained at admission to the emergency room. In areas with sustained circulation of new coronavirus, evaluation of lymphocytes could help to identify and prioritize those individuals who require and will shortly require critical care. RDW was found to be higher in COVID-19 patients, however, it had no relationship with appearance of symptoms and severity of disease. A limitation of study: its present study was lack of serial profiling of blood counts and chemistries of patients who are minimally symptomatic in general isolation. Usually, we don't do further investigations in asymptomatic patients other than at the time of admission. It is also reckoned that correlating onset of symptoms, the day of illness, with hematological parameters is important and would require a case note review that would be taken for further studies. Further studies need to be conducted comparing patients' onset of symptoms correlated with clinical condition and laboratory findings, inclusion of lymphocyte subset alteration in COVID-19. Cross references: similar studies were done in JLCA journal, Kargar journal, and ATM journal, which found that absolute lymphocyte count is an important marker in COVID-19 severity staging. But while RDW was not that significant in the preliminary study identified severe, while the first two studies showed significant correlation. Further studies needed to be done with more stringent rules and other further longer duration and higher caseloads to confirm these studies. Thank you.